All right. Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Carrie Reller, and today we have a very special guest back, Dr. Catherine Toomer, the Dr. Catherine Toomer. Welcome back to the Get Healthy Tampa Bay podcast.
Thank you for having me.
So we actually had you back on episode 47, and you shared your incredible journey into kind of where you are today. And maybe not to do the whole story, but maybe like a brief like a recap so that listeners can remember, who you are and what you do.
Okay. Well, I am Dr. Catherine Toomer. I'm a family medicine and community health physician. I also am a metabolic weight care management specialist. And that came about because of my own near-death experience. And so essentially, my environment met my genetics, and I ended up gaining a significant amount of weight from the stress of med school and a bunch of other things. And so when I had my daughter, I went into congestive heart failure and unfortunately was misdiagnosed because of my obesity. I was told that I was deconditioned and that I just had a baby and various things. Well, it turns out I was in heart failure. And in the process of trying to get my then insulin dependent diabetes under control, I did lose weight. I also survived my condition, my heart condition. But then I created a program for myself and I started using it with my patients. And then eventually that led to a practice, which then led to me training other physicians and now a virtual practice. So it's just been one thing after another.
Yeah. Yes, you definitely had quite the snowball. And I find your story, it's so interesting because, that whole phrase of making your pain your passion. And I really, feel like that's what you've done. You've learned all these things to make your own health better. And now you are, bettering the lives of your patients and now even helping other doctors do the same. So I think that's kind of what's been a little bit different since we last spoke is that you've started teaching other doctors to do what you're doing, can you tell us a little bit about that?
I started a larger program where I was helping physicians set up weight care practices that were compassionate and kind. I have spent enough time in the space to know that patients with obesity, myself included, get treated very badly often. And, not everyone is as fortunate to have a physician like you to go to, but I could only help so many. And I realized that in order for there to be more physicians like us, and I have no problem saying like us because we are a new breed in a lot of ways. And physicians wanted to know, they wanted to be able to help their patients also. And so I created a program to help train, it's a course as well as coaching. But what I found though was that there were certain parts of that process that were particularly beneficial for patients. They were very successful for patients, the ease and the access. And then the other was that it made income for physicians so that they weren't beholden to a lot of the system that held them back and prevented them from being able to help patients. And so I just kind of created that as a vertical for other physicians and trying to expand that now so that we can just help as many patients get access to medication, affordable and safe medication as possible.
I mean, I think it's amazing because I think the statistics are like 1 in 3 patients with obesity, and there's certainly not enough doctors to take care of everybody, right?
Oh.
So, being able to expand your expertise, but not only, managing, weight and obesity, but also like with the way that you do it, right? So that
Mm.
kind, gentle way that I think hasn't been in traditional medicine for a long time. It's always like, eat less, exercise more. So,
Yeah.
bringing everything that you do with that biopsycho approach really kind of ties it all together. And the way that you're teaching the other doctors about it is so important. So how would you answer that?
Well, partly because because of the psychosocial part of weight loss, weight management, having obesity, we're often preyed upon. Someone who's lost over 100 pounds, I can tell you there is this desperation within the community. There's a certain level of fear and self-blame. And so a lot of times, because of that combination of things, we're sort of sitting ducks when it comes to people wanting to take advantage of that situation. And so what ends up happening is either we're price gouged or we're, offered all these different things that may or may not work. And so what I wanted to make sure is that there was a way for people to get access that they could have confidence in and know that they're not being treated badly and they know that they're getting what's safe. And unfortunately, because of the environment we're in with the expense of branded medications, of GLP-1s particularly, because of the cost, because of the lack of coverage, because of the lack of access for a lot of people, their only option is compounded medications. I, for one, was a staunch anti-compounded physician. I mean, I'll just admit that. I was very much, I still am a little wary of compounded meds because it's so easy to get them wrong. And
Mm-hmm.
so I spent a lot of time vetting. Fortunately, the FDA has allowed certain pharmacies to compound GLP-1 medications in the face of the shortage. And what that means, though, is that there's a lot of compounded meds out there, but it also means there's a way of finding good ones. And so the FDA did give a designation that allowed me to find one that worked really well, that wasn't price gouging. I love their business model. I love the way they treated patients. And so I partnered with them in order to sort of expand across the country.
So you mentioned something like very important, I think, is what I would call it, diet culture, diet industry, is that they prey upon the patients who need the most help. And like you said, people will do anything and pay almost any amount sometimes to do this.
Mm-hmm.
And over the years, we haven't had anything quite as effective as, these new GLP, well, they're not new, but the GLP ones that have come into play. And I think it's, wonderful and exciting, but that there are many ways to do it right. In the past, there's been all these crazy diets that are just meant for like to be a short period of time, and you do it and yeah, it works, right? But then people fall off the wagon and things like that. So I think, like you said, people are preyed upon to do this thing, that's the best next thing, right? And while now we have these medications that really work, but what I like to make sure everybody is aware of is that they're really just kind of a tool in the whole, gamut of treating the patient as a whole person individually, right?
Yes.
So,
Well, like you mentioned before, biopsychosocial, the medications only hit the biology. There's
right.
still the psychosocial, and that really impacts our body's metabolic status. And so it's all, you just have to come focus also on the things that cause us stress, the
Mhm.
environment that we're eating in, the environment that we're shopping in, the environment that we move through the world in, because a lot of that makes a difference. And it makes a difference depending on the size of our body as well. And
Mhm.
also understanding that it's about health and letting your body go where it goes, regardless of the size. And so, it's not about being thin, it's about being healthy and kind of getting over the preconceived ideas, the preconceived expectations of having your body be what you want it to be. And then acceptance. Body
Mhm.
acceptance is really important as long as it's done in a healthy way and is not done in a way to ignore unhealthy habits and unhealthy ways of being.
Mm-hmm. So we're diving into this controversial topic of the compounded medications. And you said something that, was important to say, like you are concerned about them and everybody should be because, well, there's, certainly negative things if you're not going to the right place. So tell us, what are some of the risk factors or what are the things to look out for of what could, be wrong type of compounded medicine, or what are the dangers of it? What does all this mean?
So essentially what compounded medications are the reverse engineering of the brand medications, and that the FDA, where GLP-1s are concerned at least, and that's really where everybody sort of they came into focus. We've had compounded meds for a long, long time, and we've used them effectively, often for medications that we just couldn't get otherwise, but mostly topicals. I use them a lot for creams and such. But with the FDA says if there's a shortage of a medication, that there are facilities that are allowed to make copies of that medication. The issue we run into is not regulated. So the FDA can't make people make them correctly. They will monitor certain ones, and those FDA monitored facilities then produce the medications and then they provide them to third parties. Now, when they do that, it's safe in that
Mhm.
the dosing is FDA dosing, the formula are FDA formulas, and the access is regulated to a certain degree. The problem you run into is if the person selling it is also the person making it, it does lend itself to trying to maximize profit. And when you try to maximize profit, you try to keep the cost down. And the only way to keep a cost down when making medication is to skimp on the actual ingredients. And so there's a lot of variables, a lot of variation in the medication across the various compounded pharmacies. And there's no way of proving the medication's in there or not, especially when you've already paid for the medicine. And if it doesn't work, the person who's selling it has already made their money. So they don't really have a lot of incentive to create a really good product, especially when returning customers make them money. And so if you have someone who loses weight rather quickly on one dose, and then they start gaining on the second dose, and then they lose, then you come back for the third, and it just creates this vicious cycle and what's the word I'm looking for? It creates a situation where patients are preyed upon and they don't realize that's what's happening. And so, which is the best way to tell, again, which, to answer your question, going back to the best way to tell if a compounded pharmacy is good is, one, if you want it to be a 503A or 503B designation by the FDA. You also want to make sure that the doses are FDA approved. You want them to be FDA delivery. The delivery system should be what the FDA has also approved. So that means if it is either in a vial and is injected already pre-mixed, or if it's in a pen. However, the pen mechanism is proprietary and it's patented. So the likelihood of a pen delivery being approved is unlikely. Having to mix it yourself is another way of kind of understanding that this is not FDA regulated also. If the doses are these strange doses that do not go along with what the FDA has already approved for the types of medication, basically, mainly we see it a lot with the tirzepatide or the Zepbound version, or the semaglutide or Wegovy version. You have very, very distinct and very specific dosing sequences. And if they don't fit the dosing sequence, that's a huge red flag.
Well, some of them, I think they're, just drawing up from a vial. So I don't know how that would comply with dosing sequences.
Well, because you still have to prescribe it. So you still tell people, when you draw it up, you draw up this amount. It's no different than drawing up insulin, for example.
Yeah.
We've been using insulin in vials for decades, and there are ways of instructing patients on how to use them. It does lend itself to the possibility of abuse, and that's why monitoring, being prescribed by someone who knows what they're doing, is very important. Someone who monitors very closely is also very important. Being screened appropriately is also very important. But access is also very important. There are always going to be those patients who will abuse a system, that will use a new medication inappropriately. We see it with Adderall, we see it with opioids, we see it with a lot of other things. However, there are still patients who benefit greatly, and that's their only access to a medication that could be life-saving. Or you have those who actually have, who are losing access. I'm getting emails from type 2 diabetics telling me that they've lost access to their GLP-1, and it was the only thing that kept them controlled. I'm a type 2 diabetic, and I would lose control if I was not able to get my GLP-1. I white-knuckled it for years. It was really hard to keep myself controlled. It was really hard for me to keep my weight off. It was really difficult until I was put on a GLP-1 Victoza about 12 years ago. After that, it became very easy for me to maintain my health. And that's partly why I'm so adamant about helping other people, because I know how hard it is without it, and I know how easy it's been with it.
Tell me about what certain things that a non-FDA regulated pharmacy could be adding to the straight semaglutide or tirzepatide medication.
Usually it's vitamins. They'll add a vitamin because vitamins are not regulated by the FDA either, and it's considered a supplement. Supplements are not. So if you add a vitamin to the medication, it's considered a supplement, and they can bypass the FDA regulations. The other is that we don't know. Any pharmacy can add anything. I've actually, there are some that will add, low dose thyroid medication, which we know is when your thyroid controls your metabolism. So if you take a thyroid medication when you don't have a thyroid issue, it raises your metabolism, so you lose weight more quickly. But you also have other side effects. However, some of those side effects are also some of the normal side effects of medication, like palpitations, some arrhythmias, and things like that. And so that's one of the problems, is that
Mm-hmm.
anything can be added, and we have no way of knowing. And so the best way to know that nothing's been added is to know where the source is. And the source can come from an FDA regulated facility that does monitor what goes into the medication, and then nothing else gets added. And that, other than that, there's really no way of knowing what's in there.
Mm-hmm. So, well, how do you know? Like, what do they give you some sort of magic thing that says this is what you say it is? And have you ever tested the stuff from your pharmacy?
The pharmacy that I've used is a 503B. So I know that it is one of the manufacturing that the FDA does monitor.
Mm-hmm.
The best, which was all I could do, I had to have faith in that. Their dosing is exactly the same as the FDA dosing
Mm-hmm.
for the brand. So I had faith in that. And I've treated over about 500 patients using the pharmacy with amazing results. And so I can count on one hand the number of patients who either have said that they are having severe side effects and needed to stop, or which happens with any of the medications, even the brand, or they're not responding at all. Other than that, I've had no complications, but a lot of
Mm-hmm.
success. I've had many people who have been on the brand, lost access, had to go and compound it to maintain their success and maintain their health, and said they can't tell the difference. And
Mm-hmm.
to the point where I've actually had family members, I've done the same. I just had to take a leap of faith, and that
Mm-hmm.
actually paid off, because the really hard one to change your mindset, to not believe what you think. And I had to really make an adjustment when it came to injectable compound medications for the benefit for my patients and my family, because I became desperate watching people lose their health because they lost access. And unfortunately, until we get to a system where we start getting generic versions of the ones that work well, which has to happen at some point, or until the price comes down, or the access through insurance is improved, we're always going to have those who will try to fill in the gaps. And the key
Mm-hmm.
is to try to make sure that those who fill in the gaps are the good ones, and not the bad ones, and
Right.
not the dangerous ones, which, I am hoping that as people are more knowledgeable, those that are trying to price gouge, those who are trying to bypass a good system, will fall by the wayside.
So I typically those pharmacies should be offering a certificate of authenticity as well to the provider and to the patients of, this is what we say it is, right? And it's been tested X number of times or whatever.
That's only with the ones that can. And so there's a difference between who manufactures the medication and who actually distributes the medication. The pharmacies that distribute the medication, their source is important. And
Mm-hmm.
so that's where you get the certificates of authenticity and the registration, or their designation as to what type of pharmacy they are. Uh,
Mm-hmm.
Other than that, you know, there's not a whole lot. I mean, that's the problem with compounds. Some of it is just based on faith. I mean, we can't, and that's why I was so against them, because you really just don't know. And until it became absolutely necessary, I would not have, honestly, if you had asked me 5 years ago, would you trust a compounded pharmacy for your GLP-1 medication? I would have laughed.
Mm-hmm.
I said,
Yeah,
absolutely.
it's so true. I mean, I used to speak very against it because, it crosses the blood-brain barrier, right?
Mm-hmm.
I think that's, a scary thing to think that you could be putting in some impurity or additive from that compound
Mm-hmm.
medicine because you're injecting it, right? And
Yeah.
It's scary. It could be, going to the
It
brain.
is.
But, I think with the lack of access to care and the vetted 503B pharmacies, I think it can be done in a safer way. Like you said, it would be nice if things went generic, which is, Victoza or like liraglutide has since gone generic, but it's quite not doesn't have quite the efficacy of the other GLP-1s like
No, it
semaglutide
doesn't.
and tirzepatide. So we're not really seeing it being prescribed really as much anyway.
No.
But
And I can tell you, as someone who's been on Victoza and then Ozempic and now
mhm.
Mounjaro, I can tell you it's a there's not a huge difference between Ozempic and Mounjaro. The semaglutide, tirzepatide, the only time I see a huge difference in the efficacy of the two is if stress plays a huge role in weight gain.
Mhm.
Cortisol is a big problem, then I do see quite a difference, but otherwise they're about the same. There was a huge jump, however, from Victoza to Ozempic.
Yeah, yeah. Well, I definitely, have seen patients who were on Wegovy and then moved to Zepbound and did a lot better. And then maybe they were on Mounjaro when they probably didn't have diabetes. And then that all went, unable to get it. And then they got on Wegovy and they didn't have quite the success. Since then, I mean, we're recording on January 15th to 2025. So at this point in time, the Zepbound and Mounjaro are off of that shortage list. So how is that working
So they
with
claim
everything? So they,
it's
well,
actually, I mean, and I'm just going to be really blunt about this. This is a multi-billion-dollar industry. Compounded GLP-1 medications are cutting into that money for the people who are making that money. They are pressuring the FDA to say that the shortage is over. I know for a fact, I've already been on the phone 4 times this week, calling around trying to help patients get their medication because the pharmacies, the brand pharmacy, we can't get it.
mhm,
There is absolutely still a shortage, and I don't know. And so it's the only reason that declaring a non-shortage is just to hem in the GLP-1 compounded medication production. That's the only impact that will have. And,
mhm.
and it's just not true. One, semaglutide actually still has not made the non-shortage list. It's only the tirzepatide at this point.
Right,
Um,
right.
and so, which is very curious because why was there be shortage of one and not the other? I know it has something to do with manufacturing, but most of it has to do with lobbying. And so it's just simply not true. And I hate to see what will happen for those patients who do have access to really good compounded medications, who are really having a great success, who are going to lose access if that shortage is enforced. But as with the last 4 times the FDA has declared a non-shortage, they put in loopholes because they
Mhm.
know the truth. They know what the truth is, and that's why the loopholes are there, or they push it out for 90 days, or they have all these different things that allow the compounded versions to remain legal because they know the truth, and that
Mhm.
is that there is very much still a shortage.
Yeah, I mean, I still have some patients who are also having difficulty getting their Mounjaro and Zepbound. Usually they eventually get it. I will say one of the guys has not been able to get his Mounjaro for a long time. It's very odd.
I mean,
Um,
I to three
his
months
diabetes
supply,
is not as well
I was
controlled.
having such a hard time. I'm a
Yeah.
type 2 diabetic. It has kept me very well controlled. When I was getting it month to month, there were months where like weeks at a time when I could not get my medication. Um, and so now what's happening is like I get 90 day supplies. I get private insurance and I choose my insurance specifically for my access to my GLP-1 because for me that's the one medication that has improved my health more than any other medications I've had to take. I still have congestive heart failure. I have to contend with watching my ejection fraction, and my ejection fraction doubled on the GLP-1.
Well, we also can, get those like well, at least Wegovy prescribed with patients with, cardiovascular problems and obesity under Medicare, which is kind of exciting. And now obstructive sleep apnea with Zepbound. So there are ways. And then I don't know this answer, but
I think that's
rather
more
than
on
going,
policy.
what's that?
I said that's more on policy than actual fact. I mean, than we actually
Yeah,
see it happening. I
it
mean,
it has
then I
happened.
get every single PA denied until I go back and
Exactly.
phone
Yeah, there's a
call.
lot of paperwork. I was going to say though, I don't know this answer, but if a patient, instead of going on the marketplace, because I'm pretty sure marketplace doesn't have any weight care coverage, but if they went to like a private insurance, like I think you can still go buy private insurance from like United Healthcare. Can you make sure then that that would have weight management coverage or obesity medicine coverage?
Yeah, but again, it's access. I mean, who some people just I can afford it
Yeah.
as a physician. Honestly, before the Affordable Care Act and Patient Protection Act, because of my heart condition and pre-existing condition, I could not afford health insurance
Mm-hmm.
because it just was way too. I mean, it was, I think I was quoted like 6,000 a month just to get health insurance.
Yeah,
So I
that's
went,
probably, I'm just curious
yeah.
of the answer, but you're
Yeah, so
probably
I went
right.
for
The
years without
amount
it.
is probably
There
ridiculous.
is now, yes. So now with the marketplace and other things there, and because of the Patient Protection Act, we are able to get insurance with pre-existing conditions. It is still the most expensive though if you want to cover certain
Hmm.
medications, and GLP-1s are one of those. And so
Yeah, no, I don't think in marketplace you can get coverage for obesity only.
not for obesity treatment,
Right.
but one thing that they do allow, and this is something that has also been a bit of a game changer, health savings accounts and the FSA, or federal savings account, or is it, I forget what the F stands for right now.
I know.
You can use your savings accounts to pay for medications, including compounded medications. And that has made a difference because it has allowed some people to get access. Now, the biggest issue I see is not so much now getting access to compounded medications, it's getting access to physicians or any other prescriber who knows what they're doing and who will monitor very closely. They're too easy to get. And so
Yes,
too
that's
easy to
another point.
bypass. It's too easy to bypass a real prescriber or someone who's really paying attention.
So that's a good point. So with all these online companies, I can't even, there's a million. So that they are getting sometimes brand, but some of them are actually giving like compounded, like I'm
Mm-hmm.
pretty sure I
Yeah.
can think of a big one that is doing it. How do you know, or how can a patient know that that product is safe? Or what should they be looking
And
for, or what should they
they
do?
can't, and some don't care. If it works, they don't care.
Probably true.
When people get to the point again of being desperate, of understanding, seeing, there's a big social media component to it as well of what people should expect. But one of the reasons why actually I'm doing what I'm doing is for that very reason. Whatever anybody else is doing, there needs to be some entity where you have physicians who are paying attention, you have physicians who care, and who will make sure that what you get is affordable and safe.
Mhm.
And that's all I can do. And I'm able to do that, and that's what I'm doing. But I won't badmouth anyone else for what they're doing because I'm not focusing on what they're doing. I'm simply focusing on what I can do and what I can, help patients with, because there really is no way of knowing. There's no way of knowing right now what supplements we're taking because, again, they're not regulated either. So anything you're
Right.
taking that is over the counter, that's not an FDA approved medication, could be anything.
I always find it interesting that patients are much more willing to take supplements, which have no regulation more than, a prescribed medication, which usually are FDA approved and regulated. But
Yeah. I mean, a lot of
with
what
the
I do,
reservation.
I honestly had no intention of doing weight management. But what I found was that the way we are psychosocially, we focus a lot on our weight. Our weight is a symptom of our health. So, in order to get to people's health, I basically use weight as a way to help people get healthy because people will notice their weight going up and down before they notice their health deteriorating. So, what ended up happening is I added weight management in order to get people to come so that I could take care of them, their health. And that's essentially how I developed into a weight management specialist because that's what it took. Now, having said that, I can still get people to take I get a lot of patients coming to me saying I'm pre-diabetic, or my doctor told me I'm diabetic, my doctor told me I'm pre-diabetic, and I don't want to take the medicine they're prescribing, and I want you to help me lose weight so that I can not be diabetic anymore, or can get out of pre-diabetes range. And I explained, well, you do realize I'm just using the exact same medication that you're.
Yeah.
So my goal is always to get people to a place where they're managed and then back to their primary care doctor. I'm like, I don't take insurance. Don't pay me. Pay your primary care doctor. Your
Mhm.
insurance, use your insurance, and just take the medication. So I actually send a lot of patients back to their doctors that I don't help
Mhm.
because I shouldn't have to. And then there's others who are like, no, I'll rather take it with you
Mhm.
prescribing it because I know you're going to help me lose weight in the process than just taking it to treat my metabolic
Right.
problem. And I that is a mindset. I'm not quite sure how that works, but if it helps to get patients healthy, I'm like I say, I'm not going to look a gift horse in the mouth. If I'm able to help, I will help.
Are there any patients you turn away? Like if there's someone with a normal BMI or a normal lab work, or what would you say?
All the time. But at the same time, I also help patients that most patients get turned away by other doctors, mainly because, again, I've been doing this now for 15 years. I've been prescribing GLP-1 for 15 years, been on one for 12. I'm far more comfortable understanding the nuance of what the metabolic process is going on that it helps. So we know that if we lose 5-10% of our body weight, it absolutely improves our health.
Right.
No matter what your weight is, if you start losing about a certain percentage of your body weight, you do well. The converse of that is if you gain 10% of your body weight, it adversely affects your health. Well, what happens if you gain 10% of your body weight, but you don't fit the FDA criteria? Then what? If you're a menopausal woman and you start gaining weight through the middle and you start having other issues, you know there's a underlying metabolic process going on, and you're doing everything you can, building muscle, eating properly, trying to keep your stress down, and you're still just continuously gaining that visceral central fat that's affecting your health. Then what? What do you do? How do you
Mhm.
help those people? And was one of those early adopters that was using a GLP-1 for weight management before 6-Enda came out. We've always used medications off label. I am convinced, and you can quote me on this, in about the next 10 to 15 years, standard of care for women in going into menopause will be hormone replacement and a low dose GLP-1
Yeah.
medication
I had a
to
feeling you were going to
their
bring up.
weight gain
Yeah. Yeah.
and their fat
Absolutely.
production, the cardiac protection of both will be huge.
Mhm.
We already know that menopause causes cardiac issues. And a lot of the reason why it causes cardiac issues isn't just because of the hormone replacement, it's because of the unopposed cortisol. And the only thing we have right now that blocks the metabolic effects of cortisol is tirzepatide.
Interesting. Yeah. Well, semaglutide doesn't.
Not as much. There's no GIP, and it's the GIP component of
That's
tirzepatide
reasonable.
that tends
Yeah.
to work it to that advantage. That's why it actually
Oh,
works
you were
better.
mentioning that earlier. Yeah.
Yeah, it actually works better than semaglutide because of that component. And
Hmm.
mainly it's
Hmm.
because even if people don't realize that their cortisol is high or that they have issues with cortisol, which many of us walking around do because we're taught to ignore it, our stress, when people respond, that's usually why.
Yeah. Yeah.
But
Mhm.
menopausal women really respond, and mainly it's because estrogen drops, cortisol becomes unopposed, and then that GIP just blocks it.
Well, I mean, it's such an exciting future of this field too, to see what is to come. I mean,
Yeah.
not to mention the other medications coming down the line, and some of them are even compounded already, which I find bizarre, like the retrutide.
That I don't, that's the other part of the combat.
Yeah,
I absolutely do not trust any formulation that has not already come on the market through the FDA
right.
or any version of it. So there's
Oh, yeah,
oral
the oral.
semaglutide. We
Yeah, that's
have
much
that,
better.
but we don't have sublingual.
Hmm.
Even though, yes, we know that there is a delivery system that allows for sublingual delivery, we don't have it on the market. And so there's a reason why we do testing. There's a reason why there's trials and there's different phases of those trials. And, we have to trust that process. Otherwise, it just throws all of our medication out the window, just compounded.
Well, anything else to add? This has been an enlightening discussion, and it's nice to hear everybody's, or I'm sorry, your like standpoint on the
Yeah.
compounded medications and what to look out for,
Mhm.
and to,
Yeah.
realize maybe if you're having difficulty with access that maybe it isn't a right thing for you as well. So,
Yeah.
yeah.
And it's really hard, because sometimes, especially when you're a physician just starting out, or you're a physician who's maybe outside the field, for someone like me who, has been in medicine 25 years, who trained in a holistic approach. I trained at the University of Florida in Gainesville. We had an herbalist. Our PharmD was also an herbalist.
Yeah.
So we learned, all the ways that things can be done alternatively. So when that's the case, it's easier for me, I think, to adopt certain pivots in medicine, because that's kind of how I was trained. It's like use whatever tools you have at your disposal. And
Mm.
it so happens that it got to the point where compounded meds, particularly with GLP-1 medications, became a tool at my disposal, and I had to readjust my stance. It wasn't easy, but I had to,
Yeah.
because, like I said, I patients first, my ego second.
Well,
So
thank you so much for coming back on the podcast. And just a reminder, where can people find you if they want to work with you or follow you or watch you in the news? You were in the news recently again.
the best place to find me is on my website, drtoomer.com. That's drtoomer.com. And one of the things that I have done is that I will do a strategy and plan for people that don't have to work with me at all. I just want to make sure that people understand what their options are, and they can take those options wherever they want, or not even take them anywhere. But it's just so that they can be evaluated in a way that they can trust, I hope, and then decide what their best, their the best next step should be. And that all isn't always working with me.
Yeah. Yeah. Everybody, you got to find the person who works well with you. You got to find your right
Mhm.
plan. I mean, everything is going to be different for each individual. And,
Yep.
I think that's why it's super important to take this approach as such that you have as well, and the one that I do too. So,
And
yeah.
sometimes the
So,
approach is you're fine.
yeah.
You don't have to
True.
do anything, because sometimes wanting to lose weight and needing to lose
Mhm.
are not the same thing.
Yeah, a patient and I did come to that conclusion recently, and I think that, she feels good about it. And I think
Yeah,
that's
I'm one of those people. I mean, for some people, they don't want to lose too much weight, and you have to convince them that, when your metabolic process is corrected, your body's going to go where it goes, and it may be lower than what
Mhm.
you wanted it to be. And then for others, it is you're healthy and it's more than what you want it to be.
Mhm.
It's just a matter of changing expectations, understanding that, getting that diet culture out of
Yeah.
our head daily.
One patient at a time. Now you're doing it one doctor at a time. So good
Exactly,
for you.
exactly.
And, thank you so much again for coming back on, and, anytime. Yeah.
All right.
All right.
Thank you for getting on my soapbox. I know I'm a little bit.
All right. Everybody tune in next week for our next episode of the Get Healthy Tampa Bay podcast. Have a good one.